I'm going to give you a little, so everything I'm going to talk to you today is my own personal experience and what I have learned from it. And I don't know if you all remember this thing. Memory fades fast, but this was New York City. And 2009, I don't know how many of you were aware. So I'll give you a little clip of that video. So this was an airplane that took off from LaGuardia. And you can see it's the most crowded airspace and real estate in the world. And about 4 million in Manhattan itself. So this is, the flight took off from there. Very routine flight, clear day, no problems. And then less than 2 minutes after takeoff, it sustained a bird strike. So what does that mean? It lost power completely. It became a 70-ton brick that started coming down. So let's listen to the conversation. So see, Captain Sully is he's the captain, first officer is Skies. And he was flying the plane at that time. And Sullenberger was the monitoring pilot. So see the tone in his voice, you know. Everything is going fine, he's climbing down.
15.9 report to the contact on maintain 15,000. Maintain 15,000, captain 15.9.
Clear blue skies. Beautiful
every day. So 2765 maintain 10,000.
So here he hits the birds. So both engines flame out. So he has no power. They didn't realize what happened because you can't see the engines from the cockpit. So he just lost power, so he doesn't know.
Cactus 15.9, parallel thing 270.
Cactus 15.9, 8 birds to launch us and all vehicles returning back towards LaGuardia.
Okay, you need to return over. When you turn left heading up at 220.
220.
Copy of Fox's got emergency returning. That was 15.9. He first strike, he lost all engine, he lost the thrust in the engine to starting immediately. Cactus 15.9, which engines? He lost thrust in both engines. He
See,
said.
when the controller is shocked, both engines.
15.9. We can get it to you. If you want to try to land one in one break.
Certainly, what we need is Hudson.
See how calm he is? We may end up in the Hudson.
Johnny 2760, turn left 070.
So they go through their whole checklist, trying to restart the engine, trying to determine what to do.
My Cactus 15.9, city left traffic, runway 31. Okay, when do you need to land?
See, simple, precise, concise communication. And no change in his tone. He's not stressed. They might all be dead.
15.9, runway
Less
4
than 2
available.
minutes.
Do you want me to left traffic, runway 4?
What's number 2 on right, anything in New Jersey, maybe Hero?
Okay, yeah, off your right side is Teterboro Airport. Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire, actually, we're going to park down Route 13 now. Hey, guys. Cactus 15.9 on the George Washington Bridge, wants to go to the airport right now.
What's going on? Check, does he need assistance?
Yes, it was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 15.9, turn right 280, you can land runway 1 in Teterboro.
Okay, good.
Okay, which runway would you like at Teterboro?
Wherever you know.
So, this engine next to
Cactus?
you can see him coming down. We used to live right next to where this guy landed.
Cactus 15.9, you saw?
We could see this from our window. So this is the control panel of this airplane. You see how this thing is, to manage this and speak calmly is truly a feat. And if you look at this timing-wise, 2 minutes, less than 2 minutes, he hits the birds, and within another 4 minutes, he's in the water. So if you next time when you fly, just time yourself, see what happens in 4 minutes. 70-ton airplane, most dense airspace, 150 passengers. Talk about stress. So everyone survived. But look at the experience, 20,000 hours Sully, 15,000 hours Jeff Skiles. So what is it that they recognized the problem quickly, remained calm, visualized the options, decide and execute the options. They were prepared, they had been trained. They had a lot of experience. The other thing, very similar to neurosurgery, right? They train every 6 months, they are checked out. We never get, right, other than MOC once in a decade. So these guys get checked out every 6 months. If they don't pass, they can't fly, they have to do it again. So only one chance, they executed to perfection. So what do we learn from this? And why am I saying this? So this is very close to my heart. This is my personal logbook, flying logbook. You can see that it was signed by Jeff Skiles, who was the first officer. So he was my instructor in 1979. So this is very personal to me. So I've had great mentors in neurosurgery also. And this is Dr. Janetta in Pittsburgh. And this, of course, you all know. Had a black mustache, and I had more hair. And then Dr. Leonard Mallis. I don't know how many of you remember Dr. Mallis, but I worked with him. He is the one who described the transmucosal approach first. So with that, I'm going to talk to you a little bit about venous problems. We don't pay much attention to veins, so at least I didn't till I became aware of certain things. So this is a case of a patient with a clival meningioma. You can see on the MRV, many years ago I did this, don't see major veins there. So I did a transmucosal approach, and look at this. Post-op, it's a blotchy kind of hemorrhage in the temporal lobe, and the patient was quite affected by this. Why did this happen? It's a venous infarction of a temporal draining vein. Mallis always tell me, you cannot take a single temporal vein. You cannot, he said. And very true. This is another case of a subfrontal meningioma. And look at this post-op, another venous hemorrhage. And you can see how far back the sagittal sinus has been lost. So how did that happen? You know, it was an interhemispheric approach somebody did, and the sinus thrombosed backwards. This is another case that I've done recently. So here, you can see this doesn't have very good planes, big mass effect, and not only the arteries are important, the veins are important here, actually more important. So here's the arteriogram. And look at the venous face. Absolutely no veins showing up here. Not that they don't have veins, but everything is compressed by the tumor. There is no collateral going around. So there is something very important here, more than the artery. So while peeling it, there was no good plane, arachnoid plane, so this is the first post-op day CT. This is the fourth post-op day CT. You can see that this is getting bigger. He is now herniating. So this is another venous infarct because I lost a bunch of temporal veins, sylvian veins, and we had to take him back, debride it, become a bit of a mess. Another case of a clinoidal meningioma I did. Look at the scan, post-op day 1, post-op day 4. Flourishing hemorrhage, patient is aphasic, in the hospital for a long time. So, gotta pay attention to the veins. This is the pre-op, that's the sylvian vein, there is no vein of Trollard, there is no communication, and I lost that vein during the surgery. So the thing with veins is avoidance. You gotta avoid the problem before it happens. Once you have problems, then you can do other things, and I'll go over some of these with you. But once you get into trouble with veins, it's difficult to reverse it. And planning your approach, technical maneuvers during the surgery, very important here, because the veins are flimsy, not like arteries. They are unforgiving. So what about, sometimes you have to change your mind and change your approach. So here is a patient of a jugular foramen schwannoma I did some years ago. And so what would have been a normal approach? Would have been maybe a transpetrosal approach and pre-sigmoid, expose the jugular foramen, tie off the sinus, and take it out from there. But look at the angiogram. He has an emissary vein, a condylar emissary vein is the collateral, and that is the dominant sinus. So I cannot just take it, because I'll get into trouble. So what do I do? Either I just do a decompression, retrosigmoid, or some other thing. So what I did was, I did a pre-auricular infratemporal approach. Took out the foraminal part and cervical part, and decompressed some of the part in the posterior fossa. Then came back to a retrosigmoid approach, and took out the part in the posterior fossa. And this is, so first approach this way, second approach this way, leaving an island here where the condylar emissary vein is, so I did not lose it. And post-op scan looks good. What about some other maneuvers? So temporal vein again, right? So this is a clival tumor that I did some years ago. And this is the, so look at the veins here. So here I'm cutting the temporal dura, and there's a vein there, which is very anteriorly draining. It's going along the floor. There are several other veins, so it's not one vein of the vein. You've got to remember there can be more than one vein. And every one of these, the voice of Mala still rings in my ears, and my cases that I showed you. So peel it away, then divide the superior sinus, and coagulating the superior petrosal sinus, dividing it, and lifting up the temporal lobe. You can see all these veins have been preserved. And I'm working, and to limit your retraction, because you don't want to combine everything, retraction, sacrificing the veins, and the post-op MRI, the temporal lobe looks good. So that is the proof that we were able to save the vein. This is another case. So look at the angiogram. Same story as the last one. Sylvian vein, no communication with the back. So I gotta save that, right? Because this is the left side, I don't want to lose it again. So here's what I did. So here's the Sylvian vein. And I'm going to peel it away, as I'm sure you all have seen it before. But it takes some work trying to do this and preserve the vein and mobilize the temporal lobe, because I need to mobilize the temporal lobe to get to the tumor. And so small branches I took, and careful separation from the brain, and then getting enough room to pull the temporal lobe away. Always two-handed dissection. You need an excellent assistant to do all these things. Can't do it all alone. So it's teamwork. Just like Sully had a co-pilot, first officer, you need an excellent co-pilot to navigate this stuff. So here you can see how much room I get from pulling that, and the vein is preserved. Drill the clinoid, and you can see here that so you can see how much more room I have with the temporal lobe mobilized and preserving the main vein. can see afterwards, the brain looks good. No T2 signal. So if you look at the venous anatomy, there can be a lot of veins draining the temporal lobe. They will go along the floor and drain into the sinus at a distance. So you got to remember that. The other thing is, the veins don't just end up, this is on the section we did when I was at Mount Sinai, they don't just end up right going into the sinus. There are venous lakes. So when you cut the tentorium, be careful, because you might be compromising some venous drainage somewhere. So keep that in mind. So when you're cutting the tentorium, if you just willy-nilly coagulate it, might be a problem. It's better to suture it, and I'll show you an example. Also have to remember how many variations there are in the torcular. There are 3 types. These people showed. The most common is type 2, where 3 of the 4 are confluent. So when you plan your approach, you have to know this, that where is this going? Can I divide this? Can I work around this? Because even manipulations of the sinus can result in thrombosis. And we have seen that. And so you have to keep that in mind, that this can result in trouble. So these are things, my mistakes, I've learned from them, and key is to not repeat them. So here's a patient I did. The sinus looks good, the torculi is aided. So I divide the sinus in this case. I measured the sinus pressure. As you can see, here's the transverse sinus, sigmoid sinus is this way. I put a clip on it, and I'm measuring the intrasinus pressure. And before clipping and after clipping, it stays the same. And so I know there is good collateral, because these veins are valveless system. There are no valves. This is another case where the sinus is a dominant sinus, meningioma. And I decided to ligate it. And before I ligated, I measured the pressure, and didn't really, I went up only 2 points. So I divided it, we took out the tumor, but unfortunately, 2 weeks later, he came in with papilledema. And you can see that part of the torculi is occluded. So there was a thrombus in it. So it impeded the drainage, not only of the good side, which I ligated, but the other side, it is now not going through. So in those cases, for example, you have to be careful. So I always measure the pressure, look at the confluence, and look at the dominance, and then decide. Not very often we have to sacrifice the sinus, but sometimes you do. Here's a case of a small meningioma. And you have to remember that when you do a petrosal approach, you're coming like that. This place is hard to see at the pit, into the clivus, because of the angle of the temporal bone. So in a case like this, I will often do like a work in front of, and so this is a pre-sigmoid approach. I'm working with the tumor. So once I'm done with the tumor, from this view, I can see so here's I'm taking out the tumor. Here are the cranial nerves coming into view. But I can't see the pit, so I divide the dura behind the sigmoid sinus, put a Penrose drain around the sinus, pull it forward, and now I can see the pit ventral into the clivus. And there's the 7th and 8th nerves, 9th, 10th, 11th. So it gives you a good view, and I'm working on both sides of the sinus, and that's the basilar artery. So it gives you the advantage without cutting the sinus. And post-op, you can see all the temporal lobe, brain looks fine. What about if you lose the sinus, or if you lose a vein, what do you do? So this is a patient, again, pre-sigmoid petrosal approach. You can see right here that there are multiple veins draining the temporal lobe, and they're going along the floor, just like I had shown before. So when you cut the dura to cut the superior petrosal sinus, you might interrupt these veins. So it is important to preserve that. If you look at the sinus, the dominant sinus is on the right side. So it's another thing to remember, I don't want to lose the sinus while I'm working pre-sigmoid, because he needs that. And the other side is not a good drainage either. So very important to save that. So I do these cases with my ENT colleagues. So here they were drilling. So this is a pre-sigmoid approach. This is the temporal lobe. This is the pre-sigmoid drill out. So while drilling, he makes a hole into the sinus. So places gel foam and controls it. I'm still not in the OR at that time. So freeze it up, but he has left a lot of gel foam there, which is going to be in my way for the approach. So I have to take it off. What do? I can't pack it off. So I directly suture it. You can see I'm compressing it with my finger while I'm putting the stitch. So I don't stuff gel foam into the sinus because it's hard to get it out. It sticks there and you lose the sinus. So I keep compression and repair it and then proceed with the operation. And post-op, you can see that the sinus is open and the brain looks fine. This is a case of a recurrent meningioma. So it comes right into the torcula. There's a ton of tumor sticking into it. So in order to take this out, this is a grade 2 meningioma, recurred third time. Every time they were cutting and leaving a stump of tumor there. And a radiated grade 2 third operation. So I have to take this out, but I don't want to damage the torcula. So what do I do here? So this is the transverse sinus. This is the sigmoid sinus, so it's the left side approach. So here's the sigmoid now, back slope. So I'm not going to pack it because there are temporal veins too going into it. So I just suture the stump with, I think I'm using 8 O's here. Because just coagulating it, clipping it, or stuffing it with gel foam, you will lose the vein. So this is the torcula, I'm cutting towards it, I let it bleed. So with my finger, and I find where it's bleeding from. Just no random panic moves of stuffing gel foam. Just like you saw Sully fly into the Hudson without even wavering in place. So slowly, step by step, I keep cutting and putting sutures in and dealing with. So you need a very good assistant to really follow you at that time and follow it along and then repair it and get a resection. And you can see that I've cut all the way to the torcula and it's still preserved. There's no thrombosis on the other side and the other end is draining too. So this is another case. This is a first-time surgery in a young woman with this meningioma. Now, if you look at the arrows, they tell you, even though the sinus is included, there are veins coming in and the veins coming in here. So if I coagulate it or if I damage it, I will lose those veins. This is a left temporal lobe. And so I need to preserve it. How do I do that? Same maneuver as the last one. Even though the sinus is included, this is MRV. MRV never tells you the full story. I do a DSA, I do a full angiogram. And you can see there are veins. Anteriorly there are veins, posteriorly there are veins. They all need to be preserved. She is fully intact. She has this tumor. So this is the same maneuver as the last one. So here is the tumor filling the sinus. This is the left temporal lobe, cerebellum. And so this is the transverse sinus I'm cutting. Sorry. So this is the thrombus going along the pulling out the thrombus from the torcula and it starts bleeding. I oversew it. Same maneuver as the last case. And even when I go to the tentorium, you cut the tentorium up, you can see I do, so this is the stump towards the sigmoid. I clear that out, suture it. mean, it's tedious, but you can see here I'm cutting the tentorium, and there are venous lakes there. So instead of coagulating, I'm suturing them because I don't want to lose the veins that are coming in, and then I won't realize it, and post-op the patient will have trouble. And you can see the post-op, these veins are all preserved. Veins there, all preserved. And she's 5 years post-op, the brain looks fine. This was an interesting case. A colleague of mine was on call, big cerebellar infarct patient, and he wanted to do a decompressive craniectomy. This was the situation. So he called me because they got a big tear in the transverse sinus, right at the torcular. And so the key is you have to really get the bone off to get control of the sinus. You can't just cut at the edge of the sinus. You have to have a wide exposure. Otherwise you can't fix it. So here's where we got the tear. So this is, I packed it off with the cotton no gel foam inside. And it's really horrendous bleeding. I mean, you will see that. It's completely, everything is torn. It's a jagged tear into the sinus because he had used a craniotome. And so I pack it with that, then do a patch graft. Again, using 8-0 ethylons, running stitch, and so trim the graft, and so you have to put up with the bleeding. I almost lost 2 units of blood trying to fix this. So still, it's important to not pack it. You have to compression and slowly suturing it. So this, as you can see, is that's the vertex. This is the transverse sinus and the torcular end right here. And this is the so the key with these, what I've learned is, just use gentle compression. I never anticoagulate these patients. And the good thing is, and no temporary clips or anything. I don't use, because first of all, you can't even use a temporary. So that's the patch. And it's a significant size patch. It's like a 2 centimeter jagged tear. And post-op, you can see that the sinus is open, the torcular is open, and the patient did fine. Now, in extreme situations, you may need to do a bypass. So, for example, this is an F2 patient, the big pineal region tentorial meningioma, and his other meningioma also. So the venous drainage is very compromised in this patient. So you have to make sure whatever is there, don't kill it even more. So very irregular edge, very odd drainage. You can't even tell what is what, other than you got to keep what is there. So this is the case, and Shaker had described this, the combined transtentorial approach. So here I'm measuring the sinus pressure with a temporary clip on the transverse sinus. So I'm measuring the pressure there. This is the pressure. And then I'm measuring the pressure on this side to make sure that the pressure doesn't change. It has not changed. So then I decide to cut it and go ahead. But you'll see no temporary clips. I learned my lesson. So I used a Fogarty catheter within the lumen. So it's least traumatic. The clip destroys that sinus and it will thrombose. And from time to time, I just release the balloon and let it bleed out. So not really, I have not anticoagulated the patient in this. So but because it shrunk back by the time I was done with the case, I had to put a venous interposition, which I did. And again, using 8-0 ethylon running sutures, you then pull you can see the vein is draining in that direction. There it's draining. So brain looks fine, all the veins are preserved, and this is the post-op scan. The sinus is still intact. There are times I've done venous bypass bypasses in a case like this where the dominant sinus was lost during a temporal bone drill up. And she had florid papilledema post-op, cerebellum started coming out, and so this is the transverse sinus, the saphenous vein to the internal jugular vein. Another case I did was, this we had to do thrombolysis too, because I got a thrombus in it. This is using a shunt. This is a fluid and a Hara shunt during a venous bypass, but I have not been very successful with this. So the literature does have some good reports. This is from Sandu in France, 100 cases, and they did bypasses. So he says that you should bypass all of them when they involve the sinus, but I'm not sure I understand the rationale, because it's not from the sinus that they die from. They get the infarction because of the veins that are draining right at that corner. So you use Gore-Tex, all of them included. So the principle is you got to use your own tissue. 10 bypass with vein, 6 were paid. So this is a different situation than the one I did in the neck, because you got a lot of soft tissue which can collapse the vein. So my success rate hasn't been great. This is Shaker Manny, you guys have published this some time ago. Big experience with veins, basically saying the same thing. These are some other reports that I went through. So the key here is that prevention is the best option. And this Fred Gentili, you may all know, recently got the medal from the World Federation. So he presented this slide in his talk, and I found it was so touching. Lessons I've learned, which is also I have learned. Your best teacher is your last teacher. Some lessons can't be taught, they simply have to be learned. So I can't teach you. You can operate with me, you can learn things on my watch, but you have to come and make your own mistakes before you learn it. The past is where you learn, the present and future is where you apply. And ultimately, there is no such thing as failure. There are lessons to be learned in different ways. So always keep your mind open and always learn, always think through a case. Just like I showed you, these are some of the options I showed you how to deal with trouble before it happens. Just like Sully, when it happened, stay calm, deal with it, so that everybody can count on you and walk away from it. Thank you so much.